Local anesthetics are drugs that block sensory transmission from a local area to the central nervous system. They do this reversibly. The mechanism of action of local anesthetics depend on their nature. Local anesthetics, by their nature, are weak bases, with a lipophilic and a hydrophilic group linked by an amide or an ester group. At tissue pH that is 7.4, they exist in partly unionized and partly ionized states. Now here I made a mistake. This is supposed to be unionized form, that is entering the nerve exoplasm where the pH is low. Upon entering the axon, there is reionization of the local anesthetic, and thus it gains its access to the receptor in the open state of the channel. It blocks the voltage gated sodium channel from the inside, and it binds more tightly to the inactivated state of the channel. It prolongs the inactivated state, and by this it prolongs its inactivation, and thus no sodium entry is there, leading to no action potential, no impulse to the CNS, and thus local anesthesia. Looking at the factors affecting local anesthetic action, the first factor is the pKa of the anesthetic. If the pKa is increased, that means the ionized fraction is increased and the anesthetic action is decreased. So a good anesthetic, to have a rapid onset of action, needs to have a lower pKa. Second factor is the degree of plasma protein binding. Higher the plasma protein binding, longer will be the duration of the anesthetic. For example, procaine is poorly bounded while bupivacaine is highly plasma protein bound and has a longer duration of action. Thirdly, the rate of diffusion from the site of administration is also important. If higher concentration of the drug is injected, then the gradient will be higher and rapid will be the onset of action. Fourthly, the lipid solubility of the local anesthetic is also important. The more the lipid soluble, the more is the potency of the drug. For example, lignocaine is more potent than procaine. Lastly, the presence of the vasoconstrictor agent is also important, and the commonly used vasoconstrictor is adrenaline. We have three advantages to do that. Firstly, it prolongs the duration of action of the anesthetic, it decreases bleeding from the site of surgery, and thirdly, it also reduces systemic toxicity of the anesthetic by decreasing its absorption. Now, the local anesthetic has some criteria. If the local tissue to which the anesthetic is injected has a higher pH, that means the weak base, that is the local anesthetic, can exist in its unionized form and thus rapidly absorbed into the axon. Conversely, if the tissue is injured with a low pH, this will reduce the penetration of the anesthetic and decrease effectiveness. Secondly, the diameter. The greater the diameter of the nerve fiber, the longer it will take to anesthetize it. Also, myelinated fibers are blocked earlier than non-myelinated nerves of the same diameter. The sensory fibers are blocked earlier because of their high firing rate and longer duration of action potential. The fibers located in the circumference of the nerve are blocked earlier because the anesthetic reaches them first. Now, to make this a little less complicated, we'll study the pharmacological actions and the adverse effects in the same place. I'll write the pharmacological actions in blue and the adverse effects in red. Now, these effects can be divided into those on the CNS, CVS, and the skin. The CNS effects are further divided into the peripheral effects and the central effects, while the CVS effects are divided into those on the heart and those on the blood vessels. Now, peripherally, sensory fibers are blocked first and then the motor fibers are blocked. Sensory fibers are blocked first because of the increased frequency of firing. The order of blockage is such that first pain is blocked, then temperature, then touch, and then pressure. Now, the central actions initially are CNS stimulation, such as excitement, tremor, twitching, and restlessness, while in high doses there is severe CNS depression, which can lead to respiratory depression, coma, and death. Now, the depressant actions on the heart are decreased conduction velocity, decreased contractility, decreased cardiac output, decreased heart rate, increased refractory period, and decreased abnormal or pacemaker ectopic current. This is actually beneficial if we want to use these local anesthetics such as lignocaine as antiarrhythmic. They can cause arrhythmias and bradycardia. Bupivacaine is the most cardiotoxic. Now, the effect on the blood vessels are they cause blood vessel dilation, myocardial suppression or depression, decreases venous return, and thus lead to hypotension. The actions on the skin are, of course, that of anesthesia. They can also cause allergic reactions because they have sulfur groups in it. They also cause mucosal irritation. Now, there are different techniques of giving local anesthesia. One is infiltration anesthesia, second is conduction block, third is spinal anesthesia, and fourth is epidural anesthesia. Now, infiltration anesthesia is given when there is a small area of the tissue to be operated and it is injected directly into the tissue. It can be used to drain small abscesses, small swelling excisions, and cut wound laceration. The conduction block can be further divided into field block and nerve block anesthesia. Field block anesthesia is injected subcutaneously. It will anesthetize the area distal to the injection. It is used in minor procedures of the scalp, anterior abdominal wall, upper and lower extremities, etc. The nerve block anesthesia is injected very close to or around the peripheral nerve or nerve plexuses, and it will produce large areas of anesthesia. For example, brachial plexus block or cervical plexus block. In this procedure, the local anesthetic required is less than that of the field block and infiltration anesthesia. Next is the spinal anesthesia. In this procedure, the local anesthetic is injected into the subarachnoid space to anesthetize the spinal roots. The site of injection can be the space between L2 or 3 or L3 or 4. It is basically used for procedures below the level of umbilicus, for example, cesarean section, perineum surgery, etc., and OBS procedures. Now, next is the epidural anesthesia. This local anesthetic is injected into the epidural space, mainly in the thoracic or lumbar or sacral region. It will act on the spinal nerve roots. This anesthesia is used for obstetric labor. Finally, the classification. It is on the basis of structure and clinical uses. On the basis of structure, it is divided into esters and amides. On the basis of clinical uses, it's topical and injectable anesthetics. On the basis of action and potency, they are divided into slow acting, intermediate acting, and long acting local anesthetics. Now we'll see some opposite properties of the esters and the amides. Esters are short acting, while amides are intermediate acting. Esters have a slow onset of action, while amides have a rapid onset of action. Esters have poor tissue penetrating ability, while amides have a good tissue penetrating ability. Esters are metabolized by plasmacholinesterases, while amides need hepatic microsomal enzymes for their degradation. Esters can cause allergic reactions, while amides will rarely cause allergic reactions. Now, to recognize esters and amides, esters will have one I in their names, for example, cocaine, procaine, and tetracaine, while amides will have two I's, for example, bupivacaine, prilocaine, and articaine have two I's. Now, their uses are the esters are only used for infiltration and nerve block anesthesia, while the amides are used for all types of anesthesia, for example, spinal, epidural, regional block, nerve block, infiltration, and surface anesthesia. Now, on the basis of clinical uses, we divided them into topical and injectable. The topical are also known as surface anesthetics. A mnemonic to remember them is Bob TLC. Bob is a boy and we want to do his TLC. So B for binoxynate, O for oxythizane, B for butyl amino benzoate, another B for benzocaine, T for tetracaine, L for lignocaine, and C for cocaine. Now, one thing to remember about binoxynate is that it is used for corneal anesthesia. Oxythizine is used in conjunction with antacids for mucosal application in cases of gastritis. Butyl amino benzoate and benzocaine have the same functions. They're used as ointments in anal fissures and hemorrhoids and as lozenges in cases of sore throats. Now, tetracaine, despite being an ester, is a long-acting one, so it can be used in spinal anesthesia. Though we first said that short-acting esters cannot be used apart from infiltration and nerve block anesthesia, but tetracaine is an exception. Now, lignocaine, as you can see, has two I's, so it is an amide. It will have all the properties of the amide local anesthetics, and it is actually the prototype of the amide family. One thing to remember about cocaine is its intrinsic sympathomimetic activity. So we need not administer a vasoconstrictor when we are using cocaine as a local anesthetic. It decreases the reuptake of norepinephrine in central and peripheral neurons. It also has addiction liability, of course. Now, the injectable local anesthetics, we remember them with the mnemonic, please complain about little mycoplasma to be decent and respectful. Now, I know that is an odd mnemonic. You can't expect mycoplasma to be decent and respectful. But anyways, P for procaine and C for chloroprocaine. Now, we can see that both of them have one I, so they are esters and they'll have all those properties, except that procaine is a slow-acting local anesthetic, like all esters, while chloroprocaine is a fast onset local anesthetic, unlike others. They do not cause any surface anesthesia. Now, the intermediate injectable local anesthetics are articaine, lignocaine, mepivacaine, and prilocaine. Now, we can see that all of them have two I's, so they are all amides with intermediate duration of action, rapid onset, and used in all types of anesthesia. Important point about lignocaine is that they can be used in ventricular arrhythmias, and mepivacaine cannot be used in surface anesthesia. A very important point to remember about articaine and prilocaine is that both of them can cause methemoglobinemia, so you cannot give these two local anesthetics in cardiac and pulmonary disease patients. Lastly, the long-acting injectable local anesthetics are T, B, D, and R to be decent and respectful. So tetracaine, bupivacaine, dibocaine, and ropivacaine. Now, the last three are amides, while the first one is an ester. The amides will have all the properties that I mentioned earlier, and so will the ester be. Now, one important point to remember is that bupivacaine is severely cardiotoxic, and dibocaine is used as a topical anesthetic. Ropivacaine is less cardiotoxic than bupivacaine. It is still cardiotoxic, but less. That's all.